background noise. That would be great. Thank you so much. So welcome everyone. My name is Ruth Kapelis. I'm the National Content Manager and Media Relations Manager here at Breakthrough T1D. And on behalf of everybody, I'd like to welcome you to our Breakthrough T1D educational series. We're very excited to present you with more information tonight on type 1 diabetes devices and technology and how they impact management. If you've been here before, welcome back. If this is your first time joining us, welcome. I'd like to tell you a little bit about us. We are a global leader working towards a world free from type 1 diabetes through research, funding, and advocacy. We support people and families in the T1D community from the time of diagnosis by helping those living with T1D to have better, healthier, and safer lives while we work towards finding cures. We support anyone with T1D at any age or any stage, including the often underrepresented adult community. And before we begin, I'd like to say, as visitors on this land, we respectfully acknowledge that the Breakthrough T1D head office is located here, where I am, in the city of Toronto, historically known as Takaranto, covered by Treaties 13 and the Williams Treaties. And today we are gathered on the traditional lands of the Mississaugas of the Credit, the Anishinaabe, the Haudenosaunee, and the Wendat peoples. Breakthrough T1D's research and activities take place across this land where many other Indigenous inhabitants live from coast to coast to coast. We acknowledge the ancestral and unceded territories of all the Inuit, Métis, and First Nation peoples who call this land home. We are grateful to come together tonight as a community and share these lands as we support each other and work towards a world free from T1D. The education series offers a new topic approximately every other month. This is our final event of this year, but we're very excited to be back in February with a session on latent autoimmune diabetes in adults, or LADA. We also host a virtual connection series on the fourth Wednesday of each month. This is an unstructured opportunity to connect with others with no formal programming, and our last connection series will be taking place next week on Wednesday, November 26th at 12 p.m. Pacific time and 7 p.m. Eastern time. Throughout, if you have any questions, please feel free to post them in the chat. I'll just put a little notification in to let you know where that is. You can also raise your hand and we'll try to get to you at the end if we have time. Got it. And we will also have an email address in the chat function that you can have.
Can you put the light on and unlock the devices?
No, if you could mute yourself if you're at home, just so that we can reduce any background noise. So tonight we'll be discussing what devices can do for people with T1D, recent clinical practice guideline updates about automated insulin delivery use, talking with your healthcare providers about devices, the pros and cons of looped versus not looped, and more. As you know, living with type 1 diabetes means daily decisions, including the best way to administer insulin and measure blood glucose levels, for you. And we hope that this session will provide more information to help better inform and guide these decisions. And as I mentioned before, we will have the opportunity for a question and answer period, but please note we cannot answer any questions about the next generation of devices or provide any personal health advice. And it's now my pleasure to introduce our speaker tonight, Dr. Alana Wiseman, MD, PhD, FRCP, (C), Assistant Professor, University of Toronto, Division of Endocrinology and Metabolism, Mount Sinai Hospital and University Health Network. Very proud of myself for getting through that, Alana. In 2023, Dr. Wiseman was the recipient of Breakthrough T1D's Emerging Clinician Research Award. Her research focuses on the use of diabetes technologies such as insulin pumps and continuous flash glucose monitors across Canada. Her primary focus is examining the rates of diabetes technology use among people from historically marginalized communities and identifying barriers to use that can be addressed through her research. And with that, Alana, I will turn it over to you. Just got to unmute yourself, Alana. Sorry. Are you having trouble finding where your unmute is?
There, now I have it. The
Okay.
issue,
Okay.
sorry, when I was in this sharing mode, because I did not mute myself, so someone else must have muted me. Let me get the slides back up. Oh, okay, I'm still sharing. There we go. Okay, can you see the slide with the objectives and hear me now?
We can.
Okay, great. Sorry about that. Technical difficulties as we speak about technologies. So I'm pleased to be speaking at this event, in particular in November for Diabetes Month. As Ruth mentioned, this is a big area of my work, both as an endocrinologist, seeing adult patients with type 1 diabetes in Toronto, as well as in the research I do, trying to improve uptake and effective use of diabetes technologies. So today our objectives are to explain what automated insulin delivery, or AID, is and what systems are available in Canada, to discuss the benefits and challenges of AID, to review the latest guidelines that were published by Diabetes Canada, and to explore how to open the conversation about AID with your healthcare professional. So let's start with some terminology that I'll refer to throughout the presentation, just to make sure we're all starting off at a common place. So first, we'll be speaking about continuous glucose monitors, or referred to as CGM. So these are devices that track blood glucose in real time. So for example, measuring glucose levels every 1 to 5 minutes. And the devices that are available in Canada for CGM are Dexcom G6 or G7, Freestyle Libre, or the Medtronic Guardian 4. Automated insulin delivery, which we commonly refer to as AID, or hybrid closed loop, HCL, which are essentially synonyms for each other. So this is where an insulin pump and a CGM are both used. There is communication between the two devices so that the insulin is automated based on the glucose readings from the CGM. The systems that are currently available, and we'll get into some detail about this, do require mealtime boluses or announcements of food. And then finally, there's fully automated multi-hormone or fully closed-loop system, as opposed to hybrid closed-loop system. And this is the same as what I just described, except that there is no required announcement for meals or bolusing for meals. And so it's a fully automated system, and we don't have that yet available in Canada. So to review briefly options for insulin delivery in type 1 diabetes, so starting at the top figure, there's basal bolus insulin injection. So these are individuals who are not using an insulin pump, but are using injections of insulin. And we typically would give a long-acting insulin injection, also referred to as a basal insulin injection, which you can see here in the gray. So it's kind of a flat level all throughout the 24 hours of the day. And then we would give intermittent rapid acting insulin injections, typically with each meal. So as you can see here, an injection of short acting insulin for breakfast, lunch, and dinner. Moving on, the next sort of phase was insulin pump therapy. And this is quite similar to basal bolus injection, except that all of the insulin is being given as short acting insulin. And so we can try to mimic the normal pancreas function a little bit closer with insulin pump therapy. And so in the example you can see here, the basal insulin is now replaced with this flat blue line, but you can see there's a step increase early in the morning and a step decrease late in the evening. And so we can actually kind of change that long lasting or background insulin level to different insulin sensitivities at different times of the day. So that was the main advantage of pump therapy. The next generation of pump therapy was starting to integrate glucose readings from continuous glucose monitors. And so the very early versions of these basically didn't automate insulin delivery other than suspending insulin temporarily if there was a low blood glucose value or a predicted low blood glucose value. Because you can imagine if you're wearing an insulin pump and your blood sugar is low, it wouldn't make sense to keep giving insulin in that situation when you're able to shut it off temporarily. And then the next generation of integrating continuous glucose monitors with insulin pumps are automated insulin delivery, or AID, which I'll refer to it. And this is where we're currently at in the field, where an insulin pump is responding to current and predicted blood glucose values. And although there may be programmed insulin rates, the pump is automatically adjusting the insulin delivery up or down based on what's actually happening at that moment in time with the blood sugars. And so you can see that with these darker blue bars going up and going down from whatever is actually being programmed. And as mentioned, all of the systems in Canada still require announcing or bolusing for meals. So we still see this pattern of bolusing short-acting insulin for each meal. So automated insulin delivery systems have three parts: this continuous glucose monitor, or CGM, an insulin pump, or a pod, and then there's a mathematical algorithm which basically integrates the two. So insulin is increased, decreased, or paused from the pump based on readings from the CGM, as well as the algorithm's prediction of future glucose readings. All currently available systems in Canada, as I mentioned, still require entering carbohydrates or meal announcements in order to optimize the blood sugar levels post-meal. So we're fortunate to have 4 different commercially available systems in Canada. Only about 6 months ago, we had 2 options for quite a while. And then in the past 6 months, we've had 2 new options become available in Canada. So it's a really exciting time now that we have a lot more choices. So starting on the top left, we have a tandem T-Slim pump, which pairs with a Dexcom G6 or G7 CGM. And the algorithm that it uses when it's in the automated mode is called Control IQ. At the bottom left, one of the newer options is using an Ipsomed pump, and that can pair with a Dexcom G6. And the system, when it's used in the automated mode, requires currently an Android phone to run the algorithm or the predictions, and that system is called MyLife Cam APS FX. On the top right, another newer system in Canada is the Omnipod 5 system. So this is the only tubeless version of automated insulin delivery that's available right now. So it uses the Omnipod pump or patch pump, and it pairs with Dexcom G6 or G7. And then finally, on the bottom right, we have the Medtronic MiniMed 780G. So this uses the Medtronic pump with the Medtronic Guardian 4 sensor. And I will also note that although Freestyle Libre 3 is compatible with some AID systems, and although Freestyle Libre 3 is available in Canada now, it's not yet compatible with any AID systems in Canada. And then we also wanted to mention, so I just went over the 4 commercially available systems in Canada, but there are also do-it-yourself or DIY systems that some people are using. And the most common of the DIY systems being used is one called Loop. So Loop typically uses an older type of Omnipod pump. So instead of Omnipod 5, it's using typically the previous version, which is the Omnipod Dash pump. And it can be used with Dexcom G6 or Freestyle Libre. And this is an algorithm and an app that runs off of a phone, and readings can also be seen on devices such as an Apple Watch. And so this is an open source system, meaning it's being kind of built by the T1D community and being shared amongst the T1D community. But this is not a system that's undergone regulatory approval like the other systems. So it's not being kind of overseen or marketed by any particular company, but that is an option for people as well. So I'm going to go through 2 cases, and then we'll come back to these cases at the end. I'm an adult endocrinologist, so I'm going to be starting with an adult case, but we also have a pediatric case that was put forth by one of my pediatric endocrinology colleagues so that we could cover both adults and children. So this is a patient of mine. He's a man who's in his 30s. He hadn't seen an endocrinologist in quite a few years and then kind of came to see me, and his A1C is around 10%, which is higher than the target for most people of less than 7%. He often forgets to bolus. And from the get-go, when he came to see me, he told me he was interested in a pump. He was using a Freestyle Libre at the time, so this is an example of the Libre report. And I think the key thing to highlight, depending on how familiar you are with CGM, is we look at this time in the green zone. So how much time of the day is somebody spending with their blood sugar in this green zone between 3.9 to 10? And he was spending 22% on average, whereas the goal would be generally over 70%. And the other notable thing is that this time in the orange zone, or time very high with a blood sugar of more than 13.9, he was spending 50% of his time with that blood sugar. And you can see his average blood sugar overall was 14.2. So he had very high sugars overall. He was interested in starting an insulin pump. However, there were some barriers to initiating pump therapy. He was not kind of recording or logging any of his insulin doses. As I mentioned, he forgot to bolus quite frequently, and he wasn't counting carbohydrates because he generally wasn't bolusing when he was eating. And both of these were felt to be concerns by the team at the clinic I work with for how to safely initiate him on a pump, because typically we want that information in order to program the pump settings. So we'll come back to what happened with him at the end. And the second case from my pediatric colleague is in regards to a 13-month-old boy who has trisomy 21 or Down syndrome. He was admitted to the hospital in severe DKA and diagnosed with diabetes. He had a number of complications, including a blood clot, which unfortunately led to amputation of his arm. He's only 13 months, and so he weighs 8.7 kilograms, which is a very low body weight. He's experiencing significant fluctuations in blood glucose levels, and he also has feeding concerns. So the challenges in this case were extreme blood glucose fluctuations. He was requiring 6 or more injections per day. Because of his age, there was hypoglycemic unawareness. So, a 13-month-old can't communicate symptoms of hypoglycemia. There were the feeding issues, and this was a very overall traumatic situation for the family. So the barriers to insulin pump initiation in this case were that this child would require tiny insulin doses because of how small he was, that he was still admitted to hospital for other issues, including the feeding issues. So typically, when somebody's admitted to hospital is not the typical scenario for when we would initiate a pump. And another barrier was felt to be teaching the mother or the caregivers all of the information they would need during this traumatic time with so much going on with this child. So we'll come back to that case at the end as well. Management of T1D in very young children is challenging. There's high variability in insulin requirements, unpredictable eating patterns, unpredictable activity, parental fear of hypoglycemia or low blood sugars, particularly overnight. As I mentioned, limited ability to communicate symptoms of hypoglycemia if it occurs, and overall caregiver burden of management. So for children, the International Pediatric Diabetes Guidelines from ISPAD do have recommended blood sugar targets. And these are actually now completely aligned with the same targets we use for adults with T1D. So this is a hemoglobin A1C of less than 7%, as I mentioned earlier, or a time in range, that time in the green zone with a blood sugar of 3.9 to 10 of greater than 70%. So it used to be that in children, the targets were actually higher or more lenient because of the challenges in managing. But now with advances in treatments and specifically with technologies, it's felt that these are achievable targets for young children. And therefore the targets are the same as in adults. There's also a time in tight range target. So that's a more narrow blood sugar range of more than 50%. So preschool children with type 1 diabetes who have access to modern diabetes care can safely achieve a hemoglobin A1C below 6.5%. And there have been a lot of studies that support the use of AID to improve glycemic outcomes, both in children and adults. So this is a meta-analysis, which is basically where somebody takes a large number of studies of randomized controlled trials in this case, that kind of all evaluated the use of automated insulin delivery, and then combine the results from all of these studies. And this gives us a much more powerful estimation of the effect of a treatment when we can see consistency across multiple studies. And so in this meta-analysis, in total, they were able to include over 1,300 children who had been in randomized controlled trials looking at the benefits of automated insulin delivery. And they found that overall, on average, using AID increased time in range by about 164 minutes per day, so almost 3 extra hours per day spent in that green zone, as well as they decreased the time above range, so the times when the blood sugars are high, and importantly, decreased the time below range, so time with low blood sugars. And then similarly, the same was done in adults. And so now we're looking at similar studies, but done in adults with type 1 diabetes. And we see very similar effects, that the time in range increases by an average about 8%. The average glucose level, mean sensor glucose, is decreased. And again, there's reduced risks of high blood sugars, low blood sugars, reduced variability, and overall fewer adverse events or safety concerns. So these are very powerful data, underscoring the benefits of AID. And then if we go even further, this is looking at basically who is AID helpful for. And on the left, we're looking at people separated out based on their A1C before they start AID. And we can see the people in red have the highest baseline A1C, so the highest average blood sugars before starting AID. And then day 0 is when they all start an AID system. And you can see that even people with the best blood sugars at baseline based on their A1C, or based on or with the highest A1Cs at baseline, everybody actually improved. And we see the magnitude of benefit is highest for those with the highest blood sugars at baseline, which makes sense. They have the greatest room for improvement. And then on the right, we're looking at a kind of similar graph, but by age category. And again, you can see that all age categories from 0 to 12 years old all the way to 65 and up benefit from starting AID. So it really seems like these systems are beneficial for almost anyone. Importantly, AID may lessen the burden of carbohydrate counting. So as I mentioned with my patient in the case example, that was one of the concerns. But in this study, 30 people with type 1 diabetes were studied where instead of entering carbs, they just estimated their carbs in a meal as being low, medium, high, or very high. And a set number of carbs was entered for each of these meal types. And essentially what they did was compared this strategy of just estimating one of the meals as being low, medium, high, or very high carbohydrates with actually calculating the carbs and entering an exact estimation. And they found that the time in range was similar, whether using this estimation or whether actually counting carbs. And so the conclusion here was that using AID, we may not need to be really counting carbs very specifically. AID also has a number of other benefits beyond just blood sugar. So it has been shown in many studies to reduce burden and improve well-being. So it reduces diabetes distress, fear of hypoglycemia. It improves hypoglycemia unawareness, improves quality of life, and improves sleep quality. And so we can start to think of AID as having different management than we might have thought of in someone not using AID. And so the priorities can really shift from those that we prioritize when using injections of insulin. So now every day, the priority would be to wear the pump and CGM, announce meals, which could either be a carb count or even a meal size estimation. And then to activate features as needed, such as activity mode, where we target a slightly higher glucose temporarily, sleep mode, and some of the systems have options like ease off and boost, where we can kind of ramp a little bit down or ramp a little bit up in terms of the insulin delivery. Every week, we should think about changing infusion sets and refilling reservoirs, changing pods. So that might be several times per week. And then every 2 to 3 months, we should be thinking about ordering supplies. So ensuring that all of the supplies that will be needed are on hand. And then basically we need to be able to troubleshoot as needed. So if there is a failure of the pump to deliver insulin or some kind of technical issue, we need to know how to troubleshoot those challenges and what to do if a backup is needed in that situation. So we have a couple of true or false questions here. So the first question is true or false, AID has better person with type 1 diabetes reported outcomes than insulin pump therapy and CGM together. And so the answer to that is true. So AID has consistently been shown in many studies to improve outcomes that are important to people living with type 1 diabetes. Second, people who are meeting A1C and time in range target will experience added benefits transitioning to AID. So that is also true. As I showed you on the previous graphs, even those with an excellent baseline A1C at target still have benefit in their blood sugars by starting AID and still have the non-blood sugar benefits of AID as well, such as improved quality of life, reduced burden, etc. So another question, how do AID systems adjust insulin delivery in response to glucose levels? And the correct answer here is that basal insulin is adjusted based on CGM and may give correction boluses. So automated insulin delivery is kind of modulating that background insulin delivery throughout the day. And when it's detecting that a blood sugar is rising significantly or is significantly high, in addition to just adjusting the basal insulin, it may also give automatic correction boluses. And finally, the 2025 Diabetes Canada guidelines say AID blank in all individuals with type 1 diabetes for those willing to wear the device. So the options are AID may be offered, may be used, should be offered, or should be used. And the correct answer is D, should be used. So it's fairly strong language that the Diabetes Canada guidelines say AID should be used in all individuals with type 1 diabetes for those who are willing and able. So we want to take a few minutes to go over the Diabetes Canada guidelines. These were updated in 2025, so they came out fairly recently. And as stated, in kind of simple terms, the key message is that AID should be used in all individuals with type 1 diabetes, again, who are willing and able to use these devices in order to improve glycemic outcomes such as hemoglobin A1C, time in range, hypoglycemia, as well as non-glycemic outcomes such as fear of hypoglycemia, hypoglycemia awareness, diabetes distress, and quality of life. There are some challenges of tech, so I want to mention those. There are financial challenges, of course, and this is a national audience, so we know that there are differences in access and financial support programs based on the province somebody lives in and potentially based on other factors, such as their age or their age at which they were diagnosed. There is the challenge of wearing and managing multiple devices. So there are potential adhesion issues, skin issues, concerns about visibility or body image concerns, having these devices visible. Alarm fatigue. So that's a significant challenge for some people. There are alarms for low blood sugars, alarms for high blood sugars. There are alarms for technical issues, loss of signal issues. That kind of gets into the technical issues as well. So there can be signal issues, there can be inaccurate CGM readings, there can be times with interrupted insulin delivery as a result of these technical issues. And another challenge is needing to trust the algorithm. So for some people, if they're, if they're really used to and very experienced with managing their type 1 diabetes, they may have difficulty actually kind of taking a more hands-off approach and trusting the algorithm to do its thing. And so sometimes that can be a real adjustment for some people. In pediatrics, there are a few additional concerns. So wearing the device can be of concern. Children who are very active and who may not understand what the device is used for may, want to pull it out or tug on it by accident. There's a greater concern about pump failures or issues with the pump that could potentially lead to a dangerous condition called DKA or diabetic ketoacidosis. There's concern about risk for hypoglycemia with using these devices, I think particularly in smaller or younger children. Low insulin requirements, so similar to the case I presented, different devices actually have different minimum age approvals, and a lot of that is related to minimum insulin doses that have been studied or have been required for these algorithms. And then there are additional caregiver issues, as there are parents involved with managing the diabetes for a child. So, for people who are not on AID, it may be important to speak to the healthcare provider about AID, and experiences with this can differ depending on the provider's experience or expertise with AID. So our suggestions for talking to your healthcare provider, if this is an area of interest and you're not currently using AID, is to first learn what AID is. Attending a presentation like this is a great first step, and understand what it can do for you. You could consider broaching the topic with your healthcare provider, saying something like, I've been hearing about automated insulin delivery systems. Could we talk about whether one might be right for me? I would encourage you to reflect on your current diabetes management. What are the challenges, and how do you think AID might address them? Coming into an appointment armed with this knowledge and with this information might be very helpful to be persuasive. And finally, find out whether your clinic has experience with AID, and if not, find out if you can get referred somewhere that potentially has more experience. So which pump is the best for me or for my child? As we mentioned, there are 4 options available in Canada, which I think overall is a great thing that we have these options. I always like to tell my patients that I think the biggest difference, the biggest bang for your buck is starting AID, period. So if you're going from no AID to AID, you're going to get an improvement, and that's going to be regardless of which system somebody chooses. If we start to look at the differences between the systems that are available, we're going to see smaller changes in outcomes based on the differences between those systems. So some of the factors that might help someone decide are individual choice. So someone might just really gravitate toward a particular system, or might have some experience having seen it used before, or perhaps used an older version of that pump before AID was available. A big kind of branching point I find is the tubing or the tubeless. So a lot of people have very strong feelings about whether they want a tubed pump or a tubeless pump. And so that's a really key factor early on to decide, as we only have the one tubeless option. As I mentioned when we went through the systems, currently which CGMs are compatible with which pumps differs across systems. And so somebody may feel strongly which type of CGM they want to use, and then that would therefore inform which pump they could use with that sensor if they want to use it in an automated mode. And then total daily dose of insulin might be an important factor as well. So I mentioned for pediatrics, where low doses of insulin might be a concern. And then in adults, we're at the opposite end of the spectrum, where sometimes really high requirements for insulin can be a concern in some of the pumps, depending on the reservoir, how much insulin each pump can hold, and how often that would need to be changed. So let's go back to the cases. So the first case was the adult patient who wants to start on a pump. There were some barriers. Ultimately, we were able to, as a team, kind of move forward with initiating him on pump therapy, specifically AID. And he chose to use the Medtronic system. So this is a report from CareLink, which is the Medtronic platform. I won't go through it in too much detail, but I will say he's not wearing the sensor all of the time. And so when you're not wearing the CGM or the sensor, it obviously cannot be used in automated mode. And so we're seeing a 2-week time period here, where he's only wearing the CGM 60% of the time, and he's not in the automated mode the majority of the time. And we can see his time in range is 37%. However, in another time period, time B, where he's actually using the automated mode 95% of the time, we can see his time in range is 66%, which is a huge improvement from where he was at baseline. And during periods like this, where he's wearing the pump in the automated mode, his estimated A1C is now 7.4% compared to 10% before he started. So a really huge improvement and demonstration that you can start someone on AID even if they're not carbohydrate counting or recording their insulin doses. And then this is the pediatric patient, so the 13-month-old boy. So he was actually started on AID while in hospital. So I mentioned this is not usually typical, but because he had a prolonged hospitalization to sort out other issues, the team actually thought this might actually be a great opportunity to start pump therapy in a setting where he was being very closely monitored and where there was an opportunity to provide that education to the parents over a period of time, because it might have otherwise been very overwhelming. And you can see that it's not perfect, but it's a lot better than it was before. So he's spending 51% time in range, which was a lot better than he had before. So there have been some studies looking at what do people hope for or expect from AID. And I think it's helpful to know what other people hope and expect for, and maybe this aligns with some of your hopes or expectations. So first, people hope it will relieve constant burden and worry. So being able to focus more on life and not needing to plan as much around diabetes, having more freedom from diabetes, overnight in particular, there's a lot of benefit not having to worry about low blood sugars overnight. Decrease in family stress, so not thinking about diabetes as much. Again, not worrying about particularly children, especially overnight, checking their sugars while they're sleeping. Less social stress around bolusing. And finally, there's hopes or expectations for it to improve family relationships. So fewer fights, fewer, like asking family members if they've been checking their blood sugars, better moods because there's less fluctuations in blood sugars. And for children, there's less parental supervision that's needed. Additional benefits we've kind of touched on, so peace of mind, better sleep, more freedom and flexibility, improved quality of life, safety and reassurance, so fewer extreme highs and lows, and as I mentioned, especially overnight, empowerment, and connection. But it is important to mention that no system is perfect, and so we need to have reasonable expectations of what these systems can do and not expect perfect control, even with AID. So if a human focused on managing T1D every 5 minutes, 24/7, they might be able to do what an AID system does. And with that, I will close and stop sharing, and then I am happy to take questions.
Thank you so much, Alana, for that. And we had a couple of questions in the chat, so I'm just going to start. Sharon was asking if she's using the Dexcom in tandem for an AID. Are there any implications when traveling internationally, and how does a fully automated pump work when there are no boluses required?
Yeah, so for traveling internationally, we, always speak with your healthcare team, but we typically just recommend ensuring like more than adequate supplies to bring with on any travel. We also often get asked for notes for patients for travel, so that like at airport security, for example, if they have a lot of these supplies. So we're often providing letters for travel. And then we usually also recommend bringing some backups. I kind of quickly mentioned backups, I think, early on in the talk. So we usually still would recommend bringing some insulin pens for injections as a backup in case, there is any issue, because it can be difficult to troubleshoot internationally. I will say the pump companies are often really good. And so like I've had patients who have been sent replacement pumps in all places of the world when something's happened. And then the second question, remind me, was, oh, how does a fully closed loop system work? So there's a few different approaches to that. I would say in general, there's kind of two major categories. There's using the same components we have now and just trying to improve the algorithm, like those mathematical predictions. And it typically still requires like some kind of indication. It may not be like announcing carbs or a meal, but something that, to expect more glucose kind of coming into the system. So there's one version of that approved in the United States. We unfortunately don't have it available yet in Canada. That one's called the iLet. The second kind of like big branch is where we actually add another hormone, glucagon. So you may be familiar with glucagon as an emergency treatment for hypoglycemia. So another whole area of interest is, well, can you give insulin more aggressively in a pump if you have glucagon as a backup? So basically you can give more insulin knowing that if it ended up being too much, if the blood sugar is kind of coming down too much, you can start to give some glucagon as well. And so that's like the more common approach, I think, for a fully automated system. There will still be challenges. As you may know, the insulin absorption is delayed when we give it under the skin, as we do with all of our insulin administration methods. And then the CGMs are also a bit delayed as well, because we're not measuring it in the blood, we're measuring it in the fluid under the skin. And so, until we have like really fast insulins and, CGMs that have no delays, it could be challenging to fully control things 100% of the time.
So Edward asks a really good question. I think that's probably a lot of people are thinking, is how to trust the algorithm when you're not sure we'll deal aggressively enough with the rising blood glucose levels and concerned about being above range more of the time than they are now managing it without the AID.
So how do you trust the algorithm? So I think that's an important thing to talk about up front if you're considering starting AID, because as I mentioned, overall, I think going from no AID to AID, generally you see a lot of benefit regardless of which system you choose, but there are some differences, like I would say nuances and differences between the systems. And so in a situation like that, there might be one system that's more preferable to others, because the systems differ in terms of like what you can set your target glucose at. That's a key feature. So these algorithms, they may work in slightly different ways, but essentially they're all mathematically modeling, trying to get your sugar to a specific number or range. And in some of the AIDs, we can choose what that number is or that range is, and in others we can't. And so for someone who's in particular concerned about that, and if they're in particular used to, let's say, a very high time in range and striving for a very high time in range, I think that's an important discussion to have if you're thinking about AID, because there may be a system that will align better with those expectations than others. And I often find the DIY in my patients with those kind of expectations. The DIY often works well because it has the most modifiable algorithm kind of components. So you can kind of customize those ones more than the commercial systems.
Jodine says, my concern with an AID is that it could malfunction and deliver too much insulin. And are there any instances of that? I think that's probably a very common fear also.
Yeah, I think these especially the commercial systems, they undergo so much rigorous study and then regulatory approval, so review for us by Health Canada. And safety is always the primary concern. So as we've seen these systems develop over time, like the very first version of an AID was actually quite conservative because it was primarily focused on avoiding that situation of too much insulin or hypoglycemia. And it was unfortunately often at the expense of hyperglycemia or high blood sugars. And so we've seen improvements in that, but I would still say that would be a very uncommon situation that the algorithm might give too much insulin. The one situation I will say is if there's an inaccurate CGM, because the pump can only deliver insulin based on the glucose readings it's getting. And if you have experience with CGM, it's not uncommon that there, particularly toward the end of the wear time of a CGM, that there can start to be some accuracy issues. And so, that would be kind of a situation where I would say if there's going to be concern, it might be that the pump is acting on sensor readings that potentially could be inaccurate. And I think there's a lot of teaching and education about if something seems off, basically, like if the sensor is reading something and it doesn't seem correct, then you should be still poking a finger to see if that's correct or not. But I would say overall, it's not really a concern. I've seen a lot of patients on AID, and I think there was one situation I can think of where it was that sensor kind of related issue, and so the pump was giving more insulin, but very unusual.
Kent asks, in the materials you're providing, does it highlight the tube versus tubeless pump systems? Also, which pump allows more flexibility in the systems? Yeah, I mean, I know you did mention which is there's only the one tubeless option for the AID, but do you want to expand a bit more on which pump allows more flexibility in the settings?
Yeah, so the only tubeless pump in Canada is Omnipod. So the only AID options with a tubeless pump would include an Omnipod. So that's either Omnipod 5 or potentially that DIY or do-it-yourself version where you're using the older Omnipod, the Omnipod Dash. The second question was which ones are more customizable. Yeah, it's a bit of a tricky one. So I will say because they all have different features you can change, and that's different between the different systems. In terms of the specific one about the glucose target I mentioned, the newest one, CAM APS FX, so the Ipsomed pump, gives the widest range of choosing a glucose target. And I will say the Control IQ is the one that, as of the current version, we don't have any input on the glucose target at all. So that one controls to a range. It can do slightly lower during sleep mode, and it can do slightly higher during exercise mode. But in its kind of baseline status, we actually have no input on what it's targeting.
I don't see any other questions in the chat. If you wanted to raise your hand or unmute yourself if you had a question for Alana, we still have about 10 minutes left, so we can take a few more questions if there are any. Khalil, did you want to unmute yourself?
Thanks very much, Alana. This has been excellent. So really appreciate this. I'm not clear on the difference between the tubeless and the tube systems. Can you just say a bit more about what is this tubeless thing? How does it work? And if you have a view as to kind of how to think about the merits and drawbacks of that.
Yeah, so basically, like the classic insulin pump is a tubed pump, like that. Those were kind of the initial versions. So those are devices that are kind of we always said like a pager size device. A pager is like so outdated now, but essentially the size of a pager, and it holds a reservoir of insulin in it, and then there is tubing that connects that insulin to basically like a cannula that goes under the skin. And so the insulin is coming from the pump through that tube and being delivered under the skin. And so the pump needs to be worn somewhere on the body, kind of like, clipped onto the pants most commonly, but really can be clipped on anywhere. But the key is that you have kind of this tether. And so there's, some concern that there's more visibility because of that. If you're clipping it on your pants, that it's more visible. The only tubeless one we have is called Omnipod, or we call it like a patch pump. And that's where the entire pump itself is actually disposable. So it has the reservoir of insulin contained in it. The pump is the size of, I wish I had like a demo here with me, like probably like, the size of like the palm of your hand. And the whole thing gets inserted somewhere on the body with the cannula directly under it. And so there's no tubing. The insulin just goes directly from the pod into, under the skin. And then the whole thing is disposable. So every 3 days, basically a new pod has to be inserted and worn. And I think there's a whole group of people that we're waiting for an AID with the Omnipod, with the tubeless pump, because they just feel very strongly, for whatever reason, that they don't want that tubing, that tethering, that cord. It may be the visibility, it may be that they're very active. I have some adult patients who worry they have young children or toddlers or babies, that if they had the tubed pump, somebody would pull at it and disconnect it. So I think there's, a whole host of reasons, but I find that a lot of people feel very strongly about that, like the tubed or the tubeless. And I can't remember, I think there was a second part to that question.
I think
Just
that was
to say, are there,
sorry.
I mean, beyond those obvious ones, are there any other things to keep in mind in choosing the between the two? Because I mean, the tubeless seems on like in a commonsensical way, just the more obvious thing to want. So kind of what's the downside? Is it just how frequently you have to dispose of it, or is there some instability, or is it hard to insert?
Yeah, so I think that's where it kind of comes down to like all these like personal factors and things that might play into it. I would say probably the biggest limiting factor for the Omnipod pump would be that high insulin dose I referred to. So it holds the lowest amount of insulin overall. Now, for most people with type 1 diabetes, it's not an issue, but we do have some people with kind of insulin resistance, or particularly for people who are overweight or obese, they often have much higher insulin doses. And so we run into the problem that the pod may not actually last the full 3 days, and they're having to change it more often, which then also increase the costs, obviously, if you're going through the pods much more quickly. So I would say that's probably one major factor. Is not an issue for most people, but in some people it could be. And then I find the other factor like that would dissuade somebody from that pump is actually people not wanting more devices adhered to the skin. So it's bulky, it's a lot bigger than a CGM. Some people just don't want a second device. They feel kind of burdened by having so much stuff kind of attached to them. The tubeless pump, like the part that's attached to the skin is smaller.
Thank you.
Yep. Sharon, did you want to unmute yourself and ask your question? And then we have a few more in the chat, and hopefully we'll try to get to everything before the end of the session.
Sure, thank you. It's just looking at the tandem pump for children and the inability to make changes to the pump for bolus or for corrections, the inability to do that over your iPhone, that you have to have access to that child and that pump. And I'm just wondering, any sense of when in Canada we will be able to make those changes through our iPhone?
Yes, they've actually communicated about that pretty recently. So they've said by end of this month. I haven't heard an update since they sent that announcement in October, but they said in November that we will have the mobile bolus option, which is very exciting. So for those not familiar, right now with a lot of pumps and with the tandem pump, you cannot kind of give a bolus or, they essentially give a bolus or, look at the pump data on a phone, but that will be changing very soon.
So we had two questions about DIY looping and what's the best source of reliable information. And if you can just explain it a little bit further for some people who are really unfamiliar with it.
Yeah, so, DIY looping started, I think, quite a while back when there were very few options or actually even no options. So it started when we had insulin pumps and we had continuous glucose monitors, but we didn't have any of these approved systems where they communicate with each other. And so people, started thinking like, this makes no sense. I'm wearing a pump, I'm wearing a CGM, but the two are not communicating with each other. And basically, it's just that research and regulatory approvals move very slowly, right? We have to study something for a long time. We have to demonstrate it's safe in order for it to be approved and used. And so before there were actually commercial systems, like some very smart people who are generally connected to the T1D community because they have T1D or family members with T1D, who had the knowledge and ability to do this, actually started building their own algorithms. And so these are algorithms that are available for free. How they work can differ slightly depending on the system, but the most common one, Loop, most people are using it with an iPhone. They have to kind of build it themselves or with the guidance of others in the community who have experience with it. So again, like they're using an older Omnipod pump and then they're typically using a Dexcom, but they have to kind of download this app and the code and keep it up to date and then program all the settings. And for most patients starting on AID, they go through like training. So either with a diabetes educator or with a representative from that pump company, they're going through training and education on how to use this system. Whereas with a do-it-yourself, you're not getting that, obviously, because there's no company behind it. So I would say two common places to go for information. So there is a Facebook group called Loop. I don't know the number of people now, but it's like in the tens of thousands, I believe. And it was actually started by a Canadian. So a lot of people go there for kind of peer support. And then another option to look into potentially is something called BC Diabetes, British Columbia, BC Diabetes. So they are the only clinic I am aware of that help patients actually get started on a do-it-yourself system, so on Loop. So for people who might not be like Facebook users or fully able to kind of do that with the guidance of peers, BC Diabetes might be an option. I practice in Ontario. I know they see Ontario patients virtually, and it is covered still by the provincial healthcare. I can't say for certain that I know every province would be eligible for their services and for it to be covered, but it would be a good place to look into.
Thank you so much for that. Albert, you did have your hand up and it was lowered, but I just wanted to make sure that you didn't still want to ask a question.
Yeah, I did if I could. I've been on a system for a while now. Before I got on the system, I could do a dual wave bolus, which was useful for certain kinds of meals. The system doesn't have that function. And contrary to the advice of my nurse educator, I have been doing ghost carbs at what I think is the appropriate time based on my experience. Is there any way that can be worked on?
I'm curious if you're on Control IQ.
No, I'm not. I'm on the Medtronic system.
I'm sorry, which one? Medtronic?
Yes, Medtronic.
Okay, because Control IQ is also starting a dual wave bolus in early 2026, they've said. So, I think one of the nice features of all of these systems is they're all like now software upgrades. So hopefully we will see other systems as well starting to give more options like that. If I don't know specifically for the other companies if that's something that's in the works or not. I think there are some strategies like you're describing, or some people do like a percentage of the bolus up front and then the rest of it later. So there are some ways around that.
Thank you.
Oh, Ruth, you're muted
I
now.
just realized I'm muted. We only have 1 minute left, but Ken was just asking about the first patient you mentioned who was taking the CGM on and off. And is that because he said when he puts his on, it's on for 2 weeks. So he was curious about the taking it on and off part where they didn't have the full measurements in the slide that you presented.
Yeah, so I think he's wearing the pump all the time, but he's not always wearing the CGM. And so if you're not wearing the CGM, then obviously you're not using the pump in automated mode, so it would default to whatever the manual settings are. And then when we look at that data, if they're not wearing the CGM, we obviously don't get, all of that data, because we're getting it, the glucose data we're getting from the CGM. So yes, so I think overall he's still doing better, but then the focus kind of changes to, exactly, like the focus changes now. Instead of talking about carb ratios and all that kind of stuff, we're talking about like, okay, well, why aren't you wearing your sensor all the time, and what can we do to troubleshoot to get you to wear these devices? And that goes back to that slide with like how the priorities shift to every day now. It's like, okay, wearing these devices, troubleshooting these devices, instead of what's your carb ratio, what's your basal rate, and things like that.
I think we're right at 9 o'clock. So I wanted to, Alana's husband's been driving her children around so that she could deliver this presentation without them running around behind her. So I want to let them out of the car. So I will say thank you so much, Alana. This has been incredibly informative, and you are so knowledgeable, and you deliver it in such an accessible way. I just want to thank you again for giving us your evening tonight and sharing all of this information with us. I want to thank Insulet and Abbott, who have also provided support so that we can put these sessions on. And remind everyone that we have recorded this, so it will be posted to our YouTube channel tomorrow, and it will be emailed to you as well. Everyone have a great rest of your night. Have a happy holidays, and hope we'll see you back in February. Thank you again so much, Alana.
My pleasure. Bye, everybody.
Bye.